Good evening, everyone. Very happy to be here today on behalf of IHW on the World COPD Day. Okay, so let me begin by asking you this extremely simple sounding question. What, according to you, are the high five of health? I'll give you a second to think about it, but here's the answer. Well, according to me, they are good air, and I'm insisting on air right in the beginning, good water, good food, good lifestyle, and good healthcare for all. And these five actually form the pillars of the Integrated Health and Wellbeing Council Foundation, which works towards improving access, availability, and affordability of all these critical factors and elements of our life. It does this through simple 3 A's: awareness, advocacy, and action. One such example of which you're seeing right now on your screens. Now, so today, on behalf of IHW Council, which is a not-for-profit institution engaged in the health and well-being of human enterprise and existence, I'm very happy to take you along for a wonderful discussion that we've planned for you. Today, we have two extremely eminent experts lined up for you. And yes, you've guessed it right. What are we going to talk about? Managing COPD. So what is COPD? Sounds very heavy duty, doesn't it? It is heavy duty. The full form is chronic obstructive pulmonary disease. Now, this is a very complex disorder. But if I have to explain in my simple terms as a layman, give you a one-line definition, then it is a chronic inflammatory lung disease in which the alveoli, the air sacs in our lungs, do not work properly. And this leads to breathing difficulties because of obstructed airflow in the lungs. You also get symptoms like cough, mucus production, and wheezing. Rather familiar, these sound, don't they? Well, I'm not going to take any more time because we have a wonderful panel lined up for you to explain this concept and how to manage COPD better for all our collective benefits. Extremely happy to welcome Dr. Lancelot Mark Pinto, who's a consultant pulmonologist and epidemiologist at PD Hinduja Hospital and Medical Research Center, Mumbai, and Dr. Vishweshwaran B., consultant interventional pulmonology and sleep medicine at Yashoda Hospitals, Hyderabad. Together with them, we are going to try and understand this dreaded disorder better. So let's not waste any more time and dive right in. Dr. Pinto, let me begin with you. I just gave a simple layman definition. But what exactly is COPD? It sounds dreading. And also, really, how prevalent is it in Indian population? Could you just explain that to us?
Hi, Kavita, and thank you for that introduction. So COPD, like you rightly mentioned, stands for chronic. So chronic would mean something that is long-term, something that doesn't just come and go, it stays with you. Obstructive pulmonary disease, so pulmonary would mean that it involves the lungs, and obstructive would mean that it blocks the lungs in some way. It prevents you from taking a breath as freely as one would like to. This usually happens as a culmination of damages caused to the lung due to different reasons. So that damage could be cigarette smoke, for example. So it's one of the commonest respiratory diseases that you would see in an individual who has smoked cigarettes at some point of time or smoked tobacco in any form at some point of time in their lives. It could also happen because of biomass fuel. So a lot of people in India, for example, used to cook on and still continue to cook on chulas, on sigidis, which is coal, which is burnt. And those particles can injure the lung as well. It can be caused by pollution. It can be caused by other exposures, work exposures, which irritate the lungs. So what essentially happens is that you have the tubes of the lung through which air goes into the lungs. Those tubes itself can get a little blocked. They can produce a lot of mucus, as you rightly described. So a person who's chronically coughing up mucus, that could be one of the symptoms. And eventually these tubes of the lung reach a point where air and blood come together and oxygen from the air enters our blood. And that part can also get damaged, which means that whenever our body's need for oxygen increases, for example, when we're walking fast, when you're climbing stairs, when you're trying to do any strenuous activity, your lungs simply aren't able to deliver that amount of oxygen and the person ends up feeling breathless. So this is why chronic mucus secretion and shortness of breath or breathlessness tend to be the two main symptoms of this disease. Now, a lot of people assume that as you get older, a little bit of breathlessness is part of life, which is actually a misconception. There's no reason to actually be short of breath as you grow old. And if you have had exposures in the past, if you've smoked cigarettes in the past, even though it's been 10 years, 20 years since you've quit, unfortunately, the damage can be progressive and can start manifesting at a later point of time in life. So you can be in your 50s, late 50s and 60s. Typically, that's the age at which COPD manifests. And a lot of our patients come to us say that, it's been 20 years since I've not smoked a cigarette, but unfortunately that damage tends to be progressive at times and that can manifest later on in life. So this is in a nutshell what COPD is. When you talk about prevalence, so India, so low and middle income nations tend to bear the vast burden of COPD. About 90% of deaths in the world attributed to COPD happen in low and middle income nations. In India, it is the second leading cause of death. So most people don't realize, most people don't even know what the disease is, although it's the second leading cause of death. And when you talk about how common it is, so somewhere between 5 to 10% is the rough ballpark that most studies come up with, which when you see it actually converts to about somewhere between 50 to 70 million people in the country who suffer from COPD. So it's not a trivial problem. It's a problem of a large magnitude, and it's possibly going to get worse as the population grows older over time.
My God, those are absolutely staggering statistics. Really, I totally get the importance of doing this talk, and I think we should do a lot more advocacy and information sharing about this disease that, as you rightly said, not many people know much about. And you say that it's the second largest killer in the country?
In the country, yes.
Amazing. That's like really, really, that's news to me too, frankly, even though I'm a health journalist. Okay, wonderful. Sir, I'm going to move on to Dr. Vishweshwaran now. Dr. Vishweshwaran, COPD sounds dreaded, like I mentioned right in the beginning. And Dr. Pinto has, told us the symptoms and the causes, the common causes. But how, if you could elaborate, it will be really nice for the listeners and for me as well, if you can understand how does it really impact our quality of life? Does it have a huge impact? How does it show up? Dr. Vishweshwaran?
Yeah, thanks, Kavita. I think you can hear me now. So
yes.
As the name suggests, it's a chronic disorder. And as Dr. Lancelot Pinto has put, it's going to stay with you forever. So it is going to affect as long as you live. That itself signifies that how big a problem it is. The most important thing when it comes to medical science, we call it as DALY, that is disease-adjusted life years. How many years of life you will lose if you have this disease. That is quite high with respect to COPD because it is a very, very chronic phenomenon. And once you label a patient as COPD, he is going to remain COPD till the time he dies because the process is permanent and it is progressive because every year as your age progresses, your lung capacity decreases. And in a patient with a COPD, the decrease in the lung capacity is going to be much higher in comparison to a normal patient. So there are instances where we have seen patients losing their jobs, especially those who are involved where there is a certain amount of a physical work, which they are not able to do it because they cannot carry out that much stressful activities. And in addition to this, one of the most life-defining events in any patient with a COPD is what we refer to as an exacerbation. Exacerbation means like any patient who is going to have a COPD is going to experience at some point in his lifetime a worsening of his breathlessness or a cough or a phlegm, and this brings about a change in his medication. So probably he may require a hospital admission or he may have to step up on his medications. And every time one such exacerbation occurs, the lung function is going to decline much further. So every time, so this exacerbation may be 2 times a year, 3 times a year, or 4 times a year. So every time he is going to go to the hospital, that is going to impact financially on his family as well. Another thing is, once a patient of COPD advances to a more severe case, he almost becomes bedridden. He's not even able to perform his day-to-day routine activities. And there are cases of COPD who end up requiring oxygen, who end up even requiring lung transplantation. So this not only affects the person who is suffering from COPD, it is also going to have an impact on the family members, because one person for assistance is almost always required when you treat such a patient with a severe cases of COPD. So the impact of COPD on an individual level and at a family level and at a community level is very, very significant. But one unfortunate thing is, like, even though it is recognized as the second most common cause of death in India and almost third most common cause of death throughout the world, not much of importance has been given to this concept of COPD and exacerbation of COPD as we deal with a cardiac problem. So that is what, as you rightly said, awareness is the first step before you advocate and before you bring it into action. So the awareness has to spread. Just like you have a heart attack, every exacerbation of a COPD should be treated almost on a similar emergency grounds, and you should be compliant on your medications to prevent you from getting all these ill effects of COPD. So awareness is the thing that is lacking, and with such programs, probably, yes, it would make a huge difference.
No, I totally get it. I think you're very right in saying, the cost is not just on the person suffering, but his or her family and the community at large, and highlighting the problem and making it, because it is a huge problem. It's not that we are going to lie about it. It is such a huge problem. Just talking a little bit more about it, writing a little bit more about it, like they say, giving it more media space can actually be, the change that we need to bring, more awareness about this particular dreaded disorder. Dr. Pinto, you've already told us about the causes. So I guess they are very clear now: smoking, pollution, and biogas fuels. Yeah, everything. Can we also talk a little bit, if you think it'll make sense, a little bit about the stages of COPD? Are there like different stages of COPD, so that in simple terms, so that a listener could just identify if they find any of the symptoms familiar and understand what stage they could be on?
Right. So I think most of our patients commonly see us for the first time because of shortness of breath. And unfortunately, if you lead a reasonably sedentary life, a life where you're not pushing yourself, you're not running on a treadmill, you're not climbing stairs very fast on a day-to-day basis, you can lose a good 30 to 40% of your lung function before you actually start realizing that you're short of breath. So that's usually in stage 2. And all over the world, unfortunately, most COPD gets diagnosed somewhere in stage 2 or stage 3, where you've already lost a good 20 to 30% of your lung. Now, if you're a marathon runner, for example, you could lose 5% of your lung function and you would immediately realize there's a problem and you would get diagnosed earlier. But unfortunately, for the average individual who leads a reasonably sedentary life, one of the ways in which you could potentially pick it up at an early disease is to do something called a lung function test or a spirometry. Now, I'm not advocating this as a routine for everyone, but say you've been exposed to a significant quantum of cigarette smoke in your lifetime and you want to be a little proactive at some point of time, it may not be a bad idea to check what your lung function is. Now, as the disease progresses further and the lung function declines, individuals' quantum or degree of breathlessness tends to worsen. So individuals typically will initially feel shortness of breath only when they're doing things that they're unaccustomed to. So if they have to run a sudden flight of stairs or run and try to catch a train or a bus, that's when we would realize they're really short of breath. But as the disease progresses, this starts creeping into day-to-day activities. So things like showering or having a bath, going to the washroom and coming out tends to generate a little shortness of breath. Walking a little quickly on a flat surface tends to make them breathless. And then as the disease progresses even further, if it does in some individuals, even at rest, so when they're sitting quietly and doing nothing, they could still perceive some degree of shortness of breath. So roughly putting it, this would be the spectrum of the range of severity. So feeling breathless only when you push yourself to the limit versus feeling breathless even when you're sitting comfortably and doing nothing. So that's the broad spectrum in terms of severity. And unfortunately, as it progresses further, some individuals may need to use oxygen for most of their day as their oxygen levels are not maintained at rest.
Okay, so the answer, as you rightly mentioned, is probably testing in time, right? If you are at risk, you
Right.
must get tested. The way we advocate blood pressure tests, like cardiac is really made into a big, hoopla problem. So the same way, COPD also needs to be tested and caught in time is what you're trying to say, right?
That's right. Again, I wouldn't recommend it as a blanket. And a person who gets picked up on a spirometry at a screening test does not necessarily need to be treated, but you need to at least monitor them regularly. Monitor and make sure that it's not progressing with time.
Okay, good. So you need to know your risk factors, and then you need to really figure out, or maybe speak to your consultant doctor and figure out if you do need a test.
Absolutely. Absolutely.
Wonderful. Again, you did mention that usually the disease gets caught in people in 50s.
That's right.
Dr. Ishwaran, I would really like to know, is this a myth that it is an old man's problem or old woman's problem, that it only happens in the elderly, or can it affect the young as well?
So there are, sorry. So Visheshwaran, sorry, I thought it was me. Go ahead.
Yeah, okay. So as per the definition also, we term it as COPD only when the patient is more than 40 years of age. So it is not that old given the scenario where people are expected to live up to 80 to 90 years of age. So, but having said that, there are few conditions, like for example, you have some genetic abnormalities, like you call it as alpha-1 antitrypsin deficiency.
Okay.
Or you have, these days, they are saying that even a prior tuberculosis can cause a COPD-like changes. So for example, you got a tuberculosis at the age of 10 years and you have a very severely diseased lung. So that may even well fit into the criteria of the explaining it as a part of a COPD spectrum, though he doesn't fulfill the age criteria. In addition to this, patient with immunocompromised conditions like HIV, they are prone to develop COPD at a much earlier time and in much earlier age of presentation is seen.
Okay.
So generally, but having said all these things, generally, yes, the definition goes like beyond 40 years of age, you have got a risk factor, like in the form of a smoking, or you have a form of a biomass fuel exposure. And along with that, you need to do this spirometry. That's what we call it as a lung function test. And you demonstrate that there is an irreversible damage in your lung function test. Then yes, you will be labeled as COPD. But if you have any of the above said conditions which doesn't fit into this classical age criteria, you can still diagnose and treat on the lines of COPD. Okay,
so I mean, Dr. Pinto did mention about that test, which tells us about the lung function. But are there any? I mean, I'm just curious to know: are there any simpler diagnostic tests which are available that can understand how well our lungs are behaving, or our current lung health?
Yeah. See, for example, if you really want to make a diagnosis of COPD, you need to have the lung function. It doesn't go without the lung function to say that you have a COPD or not, because there are many mimickers of COPD which may require an alternate treatment. So you cannot diagnose a COPD without a lung function. That is point number one. But there can be certain lesser tests which you can try. For example, you have something called as a MMRC grading of dyspnea. That means what is the grade of the breathlessness, whether you are having breathlessness at rest or whether you are having breathlessness on walking one flight of stairs, or you have to reduce your speed while walking. So all these things can be taken as a surrogate. Probably your breathlessness is there. And in addition to this, these days, because of the COVID, there are few studies which says that you have something called as a peak expiratory flow meters. When you don't have an access to these advanced spirometers or the lung function test, even at home, you have these blowing devices which are called peak expiratory flow meters, which can roughly give you an idea. Probably my lung function is on the suboptimal range. In addition to this, especially with the times of teleconsultation where you don't have a direct access to the pulmonary function labs, there are certain questionnaires like CAT questionnaires and other COPD questionnaires, which can just guide us. Probably, yes, we are dealing with a case of COPD. But having said all these things, the definitive test, just like you have an ECG to say that the patient is having a heart attack or not, you need to have a lung function test to exactly define the diagnosis of COPD and to quantify the severity of the COPD.
So all these tests are very easily available and, like, say, across the country, or are they just available in metro cities only?
These are very, very simple tests, just like your ECG. These are nothing much complicated. And this doesn't require any much expertise. The technician can be trained in a very limited period of time.
Okay.
And it's very easy for the patient to do as well. It is not that severe or that complicated a test. So it is available everywhere. You wherever in any good clinical setup, even at a level of a healthcare clinic, you can have the spirometries being done.
So the important thing is awareness and information. People just need to know that these are the tests that they can get done, right? Yeah. Okay, great. Dr. Pinto, you did mention in the beginning, but I thought it would be nice for our listeners if we could just, maybe like we can list about 5-6 signs and symptoms people need to look out for to know that this could be COPD. I know it's a little repetitive. We've done this before, but I'm just trying to, remind people. Yeah.
Sure. No, I think that's very important to kind of self-screen at least. It won't be self-diagnosis, but screening.
Yes.
So, some myths really need to be busted that, shortness of breath under no circumstances is normal. And, whether you're growing older, whether, whatever the circumstance in life, you should never ignore shortness of breath and just assume that it's part of the aging process, should be worked up, should be investigated. So that's one common thing. Second thing is chronic production of sputum. So if you wake up with phlegm every single morning, people like to trivialize it by using words like smoker's cough or, used to be a smoker, therefore I have a cough. It's not normal. I mean, if it's a smoker's cough also, it's pathological. There is a problem because of which your lungs are irritated and are making you produce mucus on a chronic basis. So that's the second thing. So shortness of breath, if you're producing sputum on a chronic basis, on a long-term basis, clearly there is a problem that needs to be looked at. The third common symptom is a wheeze. So if you hear a whistling sound from your chest, that's clearly a problem. So, when we breathe normally, there should be zero sound, right? So a lot of people, when they breathe out, especially, will notice a small little whistle at the end of that breath, which we call a wheeze technically, and that's not to be ignored if you wheeze on a chronic basis. The other subtler symptoms are if your legs swell up, for example, as the disease progresses, sometimes swelling of the legs could be a symptom. It could also be a cardiac symptom, but again, it's something that you don't take lightly if it's a chronic problem. If you wake up at night short of breath at any point of time, that's a red flag that should never be ignored. I think these are pretty much the broad symptoms that one needs to watch out. The other thing is, if you keep having frequent coughs and colds, what Dr. Vishweshwaran alluded to earlier, these exacerbations, so every time the weather changes, every time the pollution levels increase a bit, you immediately tend to have a cough that's out of proportion to everybody else around you. So everybody's exposed to the same circumstance, but if one person consistently reacts a lot more strongly than the others, you need to start wondering if there is something chronic going on in the background, which is then getting triggered by things which are in the environment. So I think broadly, these are the things that one needs to watch out and take seriously if they're happening consistently and on a regular basis.
So the red flags, like you said, one is that if you get up at night breathless, and then the bloating in your legs, the swelling. And
right. So those tend to happen in a more advanced stage generally. Right, but in terms of overall symptoms, shortness of breath, production of mucus on a chronic basis, wheezing, these tend to be common symptoms that a person with COPD will experience.
And is there a particular symptom which, if it occurs, then you cannot waste any time but immediately consult a doctor?
No, I mean, shortness of breath, limiting your activity to an extent that you can't do basic things is always a big red flag. Okay. Waking up at night short of breath is always a red flag, even for whether it's heart disease, whether it's asthma, whether it's COPD, anything that wakes you up at night short of breath or with a tightness is never to be ignored, because that's the period when your body needs the least amount of oxygen because you've gone to sleep. All your systems are in the lowest metabolic rate, and yet if you wake up, that means there's a serious problem.
Yes. Okay, great. So another thing that I really would like you to explain maybe a little bit more, we did touch upon it earlier, but the long-term prognosis of COPD, if we can expand on that a little more, Dr. Pinto.
So I think a lot of progress has been made in the past, say 15 years or so. Once upon a time, we just had tablets for all diseases related to the respiratory system. we've realized over time that inhaled medications tend to do a much better job, at least in terms of relieving one's symptoms. So inhalers, whether it's, in the powdered form, you get capsules, which we call capsules of different kinds, which we call dry powder inhalers, or if it's the traditional pressing inhalers that one knows, from watching other people use it, or if it's nebulizations, whatever the form of therapy in an inhaled route, tends to open up the lungs, open up the tubes of the lungs, reduce the secretions, improve the perception of shortness of breath, and that can vastly improve quality of life.
Okay.
Now, whether a person will progress or not over time, there is an element of luck to that. It's not that everybody has the same trajectory. People who tend to have frequent attacks are the ones that you really need to watch out for, because, as Vishweswaran earlier pointed out, that every attack kind of takes you a step backward, a step lower in terms of your lung function. So one needs to work really hard at preventing those attacks, which land you up, which get you to a hospital, for example. Now, in terms of the long-term trajectory, we must also remember that, for example, if you have COPD because you've smoked in the past, heart disease is also strongly related to smoking in the past. So it's not just the COPD or the lung problem that might cause, it might be the other systems which are also affected by the same common risk factors, which could contribute to overall health declining over time. That being said, I don't think it is as bad as it used to be once upon a time when we couldn't relieve people's breathlessness, when they would suffer a lot. I think people can lead a very good quality of life if they're picked up at the right time, they're diagnosed at the right time, if they adhere to their treatment. So I know in India, there's a lot of reluctance to the use of inhalers. But once people start embracing that and realize that it is genuine therapy, this whole misconception that once you use it, you're going to get addicted to it, therefore you shouldn't use it. Once you overcome those kinds of barriers and you start using them on a regular basis, your quality of life can be immensely improved. And, a lot of our patients with COPD lead an essentially normal life despite having the diagnosis of COPD. So to answer your question in a nutshell, I think everybody has their own trajectory. Individual trajectories vary. So it's not one size fits all, that the moment you have a diagnosis of COPD, it means that things are going to go downhill. It's not necessarily true. And even if it progresses with time, we have a lot more in our armamentarium in terms of medications to help people live a much better quality of life than they used to maybe 20 years ago.
That's extremely heartening to hear. And I think you're very right about this block against inhalers. I see that around me all the time. I don't know what it will take for people to really understand that's the kind of therapy that you really require and that's effective. But do you see a difference from earlier to now? Is it breaking the block against inhalers a little at least?
I think the acceptance is improving over time. Also, I think public awareness campaigns have helped to a certain extent to reducing the stigma associated with it. But individuals, usually still tend to experiment at the start. Once they realize that they're consistently benefiting with it, I think the adherence improves. But the initial few months, the initial year tends to be a lot of trial and error where people do try to get off them as much as possible. And then, make peace with the fact that if it's necessary and it's benefiting them, it's something that must be good, But I think over time it has improved, yes.
Okay, wonderful. Dr. Vishweswaran, really would like to know from you, are there any specific vaccinations, that a person suffering from COPD must take, like checklist, which, they must definitely take those vaccines?
Yeah. So COPD is primarily a disorder of the lung. So these people are prone to get repeatedly infected with viruses and bacteria. Okay. So that is one of the most important reasons for the above said exacerbation. Most of these exacerbations are either because of a viral infection or a bacterial infection. So to keep yourself prevented from getting these infections, vaccination is mandatory and it's must for all cases of COPD. So we have got multitude of vaccines. The foremost important vaccine that you have to take every year is your influenza vaccine.
Okay, so because influenza vaccine.
Yeah, that has to be taken every year for a case of COPD. And the recommendations are that, in fact, every person above the 18 years of age should take an influenza vaccine, but it becomes more imperative for a COPD patient to take this influenza vaccine.
If I can just ask you, what time of the year, is there like a specific time they should take it?
So generally, we advise it to take it before the onset of the winters, that we roughly ask them to take it by the month of September. That is when the new strains of the vaccines, viruses are included in the vaccines, and the new vaccine batch comes. And every year this virus changed. So you need to take these vaccines every year.
And if someone hasn't taken it, sorry if I'm asking you, we're sitting in November, right? So if someone hasn't taken it yet, they can take it now as well, right?
Yeah, definitely.
Okay.
If you have not taken it, if you have missed by a month, it's not a problem. Any time of the year, you are still prone to get affected by some sort of influenza virus, because India falls in such a geographical locations where we have almost influenza happening around the year in one part of the state or the another. So if ideally would be to take it in the month of September, but if you have missed it, you are still eligible to take that vaccine at least once a year. So that is with respect to influenza. And the second most important vaccine that is being recommended for this COPD patient is what we refer to as a pneumococcal vaccine. So this is to prevent the COPD patient from getting infected by bacteria, which is a Streptococcus pneumoniae. So to prevent that, you need to take this pneumococcal vaccine. So we have got two different subtypes. I wouldn't dwell into the details. One we call it as a conjugated vaccine, and another we call it as a polysaccharide vaccine. So for all COPD patients who fall less than 65 years of age, they are eligible for taking this polysaccharide vaccine. That is more than sufficient until and unless they have some immunocompromising condition. But if a patient of COPD is more than 65 years of age, or he has got some other problem like underlying diabetes or a heart-related problem that suppresses his immunity, then he should ideally get a conjugated vaccine first, followed by your polysaccharide vaccine. So for general public, they need to remember that apart from your influenza vaccine, you need to take your pneumococcal vaccine as well. And recently, the 2021 guidelines on the COPD has also come up with something called as a Tdap vaccine. That is to protect yourself from diphtheria. This is a vaccine that we will give for a kid. But what they have recently realized is diphtheria is capable of causing recurrent exacerbations in a patient with COPD. And most of the vaccines that we get during our childhood, the immunity wanes off. So the current recommendation is you need to give every decade one booster dose of your Tdap vaccine, especially amongst patients of COPD, to prevent them from getting exacerbation from this diphtheria organism.
Okay, so all these three vaccines that you've mentioned are annual, so they need to be taken every year.
No. So with respect to your influenza, yes, annual. With respect to your Tdap vaccine, almost once in every decade.
Okay.
And with respect to your pneumococcal vaccine, if you are falling between 18 to 65, only one dose of polysaccharide vaccine has to be taken. But if you are either 65 or above, or if you are COPD with underlying immunosuppressed, you will take one conjugate vaccine, that is, we call it as PCV13, and you need to wait for a period of 1 year to take another dose of polysaccharide vaccine. And if 5 years interval has happened, again, you need to take one more booster dose of polysaccharide vaccine. So I didn't want to complicate things further. So your annual vaccines are just your influenza vaccines. And once in every decade, you will take a Tdap vaccine and your pneumococcal vaccine as per your guideline recommendation. In addition to this, the most important thing we should never forget right now is we are in COVID pandemic. So all these vaccine takes much lesser importance than your COVID vaccine. The first and the foremost vaccine you need to make sure is you have taken at least 2 doses of COVID vaccine. And after you have finished those COVID vaccinations, you are eligible to take all this vaccination. Never forget your COVID vaccination before you start thinking about these vaccinations.
Wonderful. I think this is an extremely important point. And I mean, doctor has explained it very, very well. But even if you're still confused about it, I suggest that you do fix up an appointment with your doctor and understand all these vaccines so that you don't miss out on any of these, because this could actually, I feel this is as important a step as any other, and it could probably save your life as well. Moving on to, I just wanted to, stress a little bit more on the risk factors. So cigarette smoking, of course, we've spoken about. Pollution is such a huge risk factor, and nothing can be really done about it. Nothing seems to be happening about it, and it's not really so much in our control. But there are any other risk factors, which can increase the prevalence of COPD, particularly for Indian population? Dr. Pinto?
Biomass fuels definitely increase the probability of getting COPD, and this whole move to trying to switch to LPG is a great move. This Ujjwal Bharat Yojana, which offers people the use of gas cylinders or natural gas versus burning materials, I think is a step in the right direction. Because a significant chunk of COPD, especially in women in our country, in whom the prevalence of smoking is lower than that in men, and yet we see quite high rates of COPD in women as well. A lot of that comes from exposure to biomass fuels, sometimes early on in life. Just the same analogy like I gave with smoking. For example, I work in Mumbai, so most of the women I see with COPD will not have used a chula since the past 20, 30, 40 years sometimes, because they migrated from a different part of the country to Mumbai. And yet they will develop COPD, unfortunately, because of that past biomass fuel exposure. So I think limiting that exposure is a step in the right direction. And I think there is political will behind it, which is good.
Yes.
Unfortunately, as you alluded to, pollution is something that can possibly cause damage. There are studies which have shown that individuals who live closer to a highway tend to have higher probability of getting COPD than individuals who live away from a highway, for example. So those are factors, of course, not under our control, but given the fact that all of us are exposed to significant quanta of pollution in our country, monitoring our respiratory health becomes all the more important for us.
Absolutely. And we have time for about 2 more questions. I thought we can talk a little bit more, just to drill the importance of quitting tobacco. So, of course, it's very, very clear that it's a direct risk factor for COPD and multiple other disorders. So, if a person does quit smoking or any other tobacco consumption, does it really reduce the risk of COPD to quite an extent? I mean, anybody could answer. Either of you could answer this question for me.
So absolutely. So this was, there were studies done a long time ago where they looked at trajectories of lung function over time. So an individual who does not smoke is, as a process of aging, as a part of aging, you lose a little bit of lung function over time. If you do smoke, you lose about double that quantum of lung function every single year. But at the point where you quit smoking, at the point where you stop smoking, that trajectory, that slope of your graph starts resembling that of an individual who does not smoke over time. So what you've lost, maybe that doesn't come back. Okay. The velocity of which your lung function declines starts resembling that of a non-smoker over time. So I think that's a very strong reason to give up smoking, because maybe there is some damage which is being done, but you can still prevent a lot of damage from happening from the point at which you quit.
Wonderful. The last question, which is really important, and it's a very practical question, which I feel will help a lot of, the answer will help a lot of listeners today. Dr. Vishweshwaran, exercise, we keep talking about the importance of exercise and, how everyone must exercise. So for a COPD person, somebody who's suffering from COPD, what are the guidelines for exercise? How should they exercise, first of all? If yes, how should they exercise? And thirdly, which are the exercises that can actually benefit?
Okay, so the most important point to note here is, like, most of the COPD thinks that once they start walking, they are breathless and they need to stop walking or decrease their activity. That is totally wrong. Because you have a breathing problem, you decrease your activity, your muscle becomes more weak. So this contributes to increased breathlessness. This is what we refer to as a vicious cycle. So we need to break this cycle at some point of time. So the thing is, definitely, yes, a COPD patient will tend to become more breathless than you when he's doing any activity, but he need to modify his activity and he need to continue his day-to-day activities to prevent the muscle from going into deconditioning or the muscle from going into atrophy. That means the muscle becomes waste if you don't use it.
Okay.
So there comes the important role of what we refer to as a pulmonary rehabilitation. So apart from all the medicines and the vaccines, you have one of the most important strategies that has been found to be very effective almost in all patients of COPD in various spectrums of COPD is pulmonary rehabilitation.
Okay.
So the most important thing in the pulmonary rehabilitation is how to make these muscles work properly. So you have few exercises where you call something called as a diaphragmatic breathing. So what you do is you just keep your hands over your diaphragm and you try to blow out the air, keeping your mouth closed. So this will help. Like it's like this is what we refer to as a pursed lip breathing. You keep your mouth closed and you try to slowly exhale the air as much as possible. So the rationale behind is what really happens in COPD is you have a tube. Now the tube is getting blocked. One because of the contraction, another because of the secretion. So when a person takes in air, the air goes in, but it doesn't come out. So when the air doesn't come out, the lung keeps expanding, 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 and it becomes like a balloon which is totally hyperinflated. Now you want to reduce this balloon from becoming hyperinflated so that the patient can normally breathe. So that is what we are trying to achieve by making these patients blow out slowly through their mouth, keeping their mouth almost near partially closed, so that when they slowly breathe out, this balloon which has been totally inflated will now slowly shrink. So this prevents what we refer to as a hyperinflation. That is one of the most simple techniques which they can use. And another is they need to do something called as a diaphragmatic breathing. They need to concentrate on their diaphragm when they slowly exhale this breath. And apart from that, you can use simple dumbbells. You need not do any gym sort of thing. You can use simple dumbbells, or you can use something called as a hand grip devices. So those devices can be used to make your peripheral muscles act. And you need to start walking. You walk to a point until you start feeling breathlessness and then take a break. Don't exert yourself too much, because the moment you are going to exert yourself too much, again, you are going to enter this vicious cycle of hyperinflation. So you continue walking, you slow down your pace of walking. The moment you start feeling that I'm breathless, take a break and again continue walking. In that way, you will not put overstretch on your lung and the diaphragmatic muscles. And the other thing is you need to work on the muscles around your chest. So there are a lot of exercises which a proper physiotherapist can guide you to. You need to strengthen not only your lungs, you need to strengthen the muscles around your lungs. So they will give you some limb raising exercises. They will give you some dumbbell exercises. They will make your quadriceps. One of the most important problems with COPD is you have a wasting of the muscles of the leg, that we call it as the quadriceps, or the other muscles are the hamstring muscles. These are the muscles which gets wasted because these people don't walk. So there are few exercises which are used to strengthen this, so that when your muscle is good, the amount of the stress that is put on your lungs for walking becomes less. So you are trying to enhance the other apparatus of the body which are capable of assisting in your day-to-day activities, apart from concentrating only on the lungs. So these are the few exercises which has to be done. But the point in rehabilitation is, yes, it works very good and there are so much of scientific data to back it up, but the effect goes off if you don't do it on a repeated basis. Because this problem is a long-term problem. And it's not like you enter into a rehabilitation, do it for 8 weeks, you come back and you forget. No, it doesn't go away with it. Just like you take a medication for your diabetes or a hypertension or a heart problem, when you are entering into the rehabilitation, make your mind that it's going to be a recurring process. You have to do it on day-to-day basis, because your problem is going to get worsened with ages to come. So you need to make sure that you do this rehabilitation continuously to keep yourself fit, at least for doing your day-to-day activities. So another important aspect in all cases of COPD is neglect of nutrition, especially amongst a middle and low income country like ours. Many people are concentrated on giving inhalers, putting them on medications, but most of them in a busy practice, what they neglect is nutritional status. You need to optimally build up their nutrition. You need to make sure they don't have the systemic side effects of COPD, like the patient may have a low vitamin D levels, the patient may have a low calcium levels. You need to augment all these things in addition to just treating them as a case of COPD with just inhalers.
And enough protein as well, because which is lacking in the diets of most people, and it can lead to dire situation in a COPD person. I mean, that's what I realized. I think it's been such a wonderful discussion and a lot of key takeaways from this. Of course, the first most important key takeaway, as I understand, is awareness, and we need to really talk about it. So I really thank both of you for doing this today for IHW, because the way you've explained the disease, I'm sure it becomes less of an enigma for, it will become less of an enigma for people and more something that they can understand. So once you understand, you can tackle a problem. So that is the most important thing. And second, like both of you have reiterated again and again, it needs to be caught in time. And then once caught, it needs to be managed so that it doesn't progress. And the good silver lining, as you mentioned, and which sounds very heartening to me, and I'm sure to all the listeners, is that it can be managed very well now, is what both of you are saying. It's not a death threat or something which is that you give up if you come to know that you've got COPD, right? So life, as you mentioned, can stay normal very easily as long as you stay on the right course. So I think this has been a very good discussion. I've learned a lot, and we hope to do this again with you so that more and more people can benefit from this. And I would really like to thank both of you from IHW and for me personally for sharing the information with us. Thank you for coming.
Thank you, Kavita.
Thank you.